Okay, let's get started. And welcome to this webinar presented by the CortiCare educational webinar system. And I'd like to just say a couple of words here first. One is that the webinar is being recorded, and shortly after the webinar, within an hour or two after, you'll get a link to the recording so you can review this, because the content is pretty heavy. It's excellent, and I think it's something that you'll want to review. The presenter today is going to be talking about frontal lobe epilepsy. And Dr. Navita Kaushal is certainly well qualified to discuss this, as well as the additional topics that she'll be presenting later this year. She received her original training back in India, but then continued her training in the United States, including working at the Jefferson Hospital in Philadelphia and becoming part of the faculty at Delaware Community College in Pennsylvania. And more currently, she has been with CortiCare for the last 3 years and really has added to the quality of our staff and our company. And I am certainly pleased to have her on board presenting today's topic. I will now sign off and let Dr. Kaushal continue.
Good evening, everyone. My topic for today evening's talk is frontal lobe epilepsy. We're going to talk about frontal lobe seizures, functions of frontal lobe, various seizures originating from different parts of the frontal lobe. And we will go over some of the semiology and the EEG of the frontal lobe seizures. So we're going to back and forth. I have some videos from International League Against Epilepsy and some EEG samples. So we're going to go back and forth between my presentation and the videos. So frontal lobe, it covers almost 40% of the cerebral cortex. And that said, it is one of the largest lobes. And it has 3 cortical surfaces: lateral, medial, and the inferior. There are 4 gyri. And we know the precentral gyri is the one that is for the motor functions. That's where our motor strip lies. And 3 sulci: superior, inferior, and precentral. The inferior sulci is the one where Broca's lie. That is the language center of the brain. Along with that, we have various regions that we will be talking about during this webinar, because we're going to discuss different seizures originating from different parts, like the frontopolar, very anterior, orbitofrontal, which is inferior, lateral inferior, has a very close proximity to the temporal lobe, frontal convexity, and the supplementary motor area, which is right anterior to the motor cortex. Anterior mesial frontal, which is in the middle, in the anterior medial part of the brain. Coming to the functions of frontal lobe, it is a center of executive function and cognitive skills. The motor strip lies right in the frontal lobe, so all the motor functions are controlled by the frontal lobe. Voluntary movements, expressive language due to presence of Broca, emotions, problem solving, judgment, social and sexual behavior. How to behave, when to behave, and how to behave where you are. It's all about the functional nature of the frontal lobe. Frontal lobe is definitely one of the largest and the second most seizures, the number of seizures that originate from the frontal lobe. So just revising a little bit more of neuroanatomy, if you remember homunculus, on the red outline of the cortex shows the motor cortex. It reflects how the brain kind of represents our body when it comes to controlling them. The most of the area of the lateral aspect of the frontal lobe controls the face. And the superior medial part is for the torso. movement of hand, and the inferior part, that's where the language and the control of the pharynx, control of your buccal muscles and everything is on the lateral inferior part of the frontal lobe. And frontal lobe receive connections from all over the brain, basically. If you look at these projection fibers, which are running from cortical to cortical, that means from one part of the gyrus to another part of the gyrus, from frontal to the parietal lobe, the occipital frontal or fronto-occipital tracts, or the fascicles, which connect the occipital lobe to the frontal lobe. Quite thick projections from the temporal to the frontal lobe, not just the medial aspect or the posterior aspect of the temporal lobe, also the anterior part of the frontal lobe is connected to the temporal lobe. Thalamus, the deeper areas of the brain, also send projections to the frontal lobe. This is just another colorful cartoon to show you the anterior, posterior, and the lateral, the hemispheric connections of the frontal lobe. The frontal lobe seizure. So I'm not going to talk different types of epilepsies. I'm going to focus my talk mostly on the seizures in frontal lobe epilepsy. That is altogether going to be a different talk, cannot fit all the contents in one. So we will discuss the frontal lobe seizures. These seizures are focal seizures. They do become generalized. All the frontal lobe seizures start as focal seizures. Either they stick to just that area, or if they generalize, according to the 2017 classification of the seizures, we call them focal to bilateral tonic-clonic. We're not calling them generalized tonic-clonic. So these seizures originate focal in one part of the frontal lobe, and then they generalizes and move along to the other part of the brain. As we saw, there are very heavy connections, heavy projections between the lobes of the brain with the frontal lobe. So what are the causes for these seizures? Like the very first line that you open, any textbook, any article you open, what is the cause for a seizure? So it's as of now, we are still not 100% sure. It is unknown physiological mechanisms that are causing these seizures. More and more research is being conducted, and the latest review article that I came across is talking more about lesions than any other idiopathic reason. The imbalance of electrical inhibition and excitation of the neurons in the frontal lobe, cortical dysplasia, which is more of a malformation of cortical development, which is usually in utero kind of a condition. So babies are born with cortical dysplasia. Tumors, vascular malformations, any post-traumatic encephalomalacia, lipofuscin accumulation, and channels, which is the bigger cause of autosomal dominant nocturnal frontal lobe epilepsy. The nicotine acetylcholine receptor channels are either malfunctioned or they are not properly functioning, can lead to frontal lobe seizures. A little bit of history of the frontal lobe. To go back 1800s, the biggest patient who initiated that, okay, brain is responsible to make us who we are, our behavior, our projection towards the society, was the patient Phineas Gage in 1800s, who got injured while working at the railroad. He had this big metal rod pierced his face, came out of his frontal bone. He did survive, but his persona kind of changed completely. That initiated, okay, the frontal lobe is definitely responsible to have certain characteristics of a person. So far, the seizures go, 1827, very first description of a focal clonic seizure. And Bravis figured that this is originating from the posterior frontal lobe. Now, you all have heard of, we have all described Jacksonian march, right? So march of spasm, that term was coined by Dr. Jackson in 1867, where he reported that these seizures are originating from the contralateral perirolandic area. And to make this term immortal, the International League Against Epilepsy named it as Jacksonian March. Instead of March of Spasms, it's named Jacksonian March in 1989. But this term, this kind of semiology of frontal lobe seizure was coined in 1867. The electrical stimulation of the brain, 1951, Penfield and Welch, they were the pioneer in the electrical stimulation of the brain and figuring out different functions of different parts of the brain. So when stimulated the frontal lobe, certain areas of frontal lobe, they cause speech and behavior arrest, vocalization, contralateral posturing, which we commonly known as fencer's position or sign of 4. So all these symptoms originated when they stimulated Brodmann area 6, or in other terms, it is supplementary motor area. And pharmacologically, the seizures were induced by another scientist in 1957. It has more or less the similar semiology, similar clinical features as that of fencer's position, and it is named as M2E posturing. Now here, there was no loss of consciousness, or the seizure did not secondary generalized. So these research was conducted closer to each other. So the electrical stimulation and the pharmacological induced seizures kind of produced certain characteristics of seizures which were originating from the frontal lobe. These seizures, they are shorter in duration as compared to the temporal lobe seizures. So sometimes it's very it's a little bit difficult to figure out if it is a temporal lobe seizure or if it's a frontal lobe seizures, because parts of frontal lobe is definitely in close proximity to temporal lobe. The frontal lobe seizures occur during the night. It doesn't mean they don't happen during the day, but most of the seizures are happening during the night. And remember, when there are frontal lobe seizures, the patient wakes up after the seizure. After the seizure is over, it lasts for a couple of seconds, 10 seconds to 40 to 50 seconds. The consciousness during the frontal lobe seizures is preserved. So that means there is no loss of consciousness. Consciousness may be altered, but it is not lost completely. There is a minimal postictal confusion, but you would still see postictal confusion if the seizure is spreading to the temporal lobe. These seizures are highly associated with sleep-wake cycles, and they can happen in clusters. So brief happen during the night, happen during the sleep, and can happen in clusters, 50 to 70 in a row. So imagine somebody having these many seizures during their sleep. Cognitive impairment is a must, right? It's going to happen. The patient usually has verbal and executive function deficits. Now, these seizures, if left untreated or unnoticed, they can evolve into convulsive seizures, or they can evolve into non-convulsive status epilepticus, because consciousness is not fully impaired. Consciousness is partially impaired. A person is still aware of their surrounding around them, but they seem to be confused. Over the years, many names were given to the frontal lobe seizures. Focal clonic seizure, Jacksonian March seizures, supplementary sensory motor seizures, because some of these seizures not only have motor component, but they do have sensory component too. Hemiclonic seizures, it's because there is no Jacksonian March, but there is convulsions only on one side of the body. And if these seizures persist, if they are not treated, it can evolve into epilepsia partialis continua. However, International League Against Epilepsy in 2017 classified frontal lobe seizures as of focal onset. So remember, this classification is based on onset. It is not based on the localization. We are not saying this is a frontal lobe seizure. We are classifying it as focal onset, aware or with impaired awareness. Now, at the bottom of this classification, there is one more section here which says focal to bilateral tonic-clonic. So focal onset seizures in the frontal lobe can evolve. If they become generalized, they fall into category of focal to bilateral tonic-clonic seizure. The clinical features. The clinical features of the frontal lobe seizures are definitely motor. since we have the motor strip sitting right there, almost all the seizures, with few exceptions, have motor features. The aura is non-specific. The patient cannot describe very clear-cut aura that, okay, they're feeling like this as compared to the temporal lobe seizures. They happen during night. They are in clusters. They are of very short duration, and they are Jacksonian march seizures. So they start in one tiny segment, the distal part of the body, could be the finger, move on to the hand, to the arm, to the shoulder, and it can become generalized. Posturing is another sign that we see with the frontal lobe seizure. So that means the entire motor strip is involved. Hyperkinetic movements are also seen during frontal lobe seizures. That is what differentiates the frontal lobe seizures from temporal lobe seizures. The movements are big, movements are huge, high amplitude movements like bicycling, pedaling. There is motor arrest. So we have motor cortex, we have supplementary motor cortex, and then pre-supplementary motor cortex. So those three areas, so there is areas, the pre-supplementary motor area, if the seizure is originating from that, it causes motor arrest. Speech arrest, we all know Broca is sitting right there. That is a negative phenomena. Vocalization is a positive phenomena of the frontal lobe seizure. So the area of the Broca is involved and the patient is making garbled up like a salad of speech, basically. Olfactory aura, that is something that is kind of sitting right there with the temporal lobe. So olfactory aura is a sign of frontal lobe seizures. Patients are thrashing and kicking. So the patient have very prominent vocalization, bizarre behavior, unacceptable social behavior, urinary incontinence, and deviation of head and eye, along with all the features that we just talked about. Now the auras are being reported, but they are not very clear-cut. However, you cannot differentiate these auras between the frontal or the temporal region. The auras for the frontal lobe seizures are very unspecific. They are not clearly explainable, and they are localized to the head. The patient has some feeling, but they cannot express it. They cannot say what it is. And the asymmetric tonic seizures, which are originating from the supplementary motor area, they are often preceded by somatosensory area. So there is a very heavy projection from the sensory cortex to the supplementary motor area. So you have central sulcus, anterior to that is a motor cortex, and anterior to that is a supplementary motor area. So that area has heavily connection with the parietal lobe sensory cortex. So patients do report somatosensory aura, and that after that aura, they do have asymmetric tonic seizures. Patients have reported autonomic auras like nausea or palpitations, and some emotional auras such as fear. Let's talk about different areas of the frontal lobe and the seizures originating from them. So again, revising that anatomy slide for the brain. So we have central sulcus running like this. Anterior to central sulcus is a precentral gyrus. This is our motor strip. Behind the central sulcus is a postcentral gyrus. That is our somatosensory cortex. Here is the supplementary motor area. So any seizures that are originating from the primary motor, that the precentral gyrus, they are of focal clonic nature. From the supplementary motor area, they are asymmetric tonic seizures. The frontal convexity is producing hyperactive seizures. The orbitofrontal area, which is lateral inferior part of the frontal lobe, it produces hyperkinetic seizures, and somehow these seizures are easily confused with the temporal lobe because of its close proximity. Then we have the frontopolar region. Again, seizures are asymmetric tonic seizures. They are also hyperactive seizure. Then there is operculum. Operculum is the area right above the insular lobe that the seizures which originate from there are of masticatory nature. That means the patient is chewing and salivating. Insula is responsible for the gustatory functions, and because of the projections from the top of the cortex, the frontal lobe, to the insula, so seizures will have some of the similarities of the insular seizures. Let's talk a little bit in detail about them. So focal clonic motor seizures, they are the primary motor cortex seizures. Now, here, there is a thing, the symptomatic and the epileptogenic zone, right? So the seizures, wherever you are seeing seizures, what are symptoms you are seeing, they are not originating from that point. We have epileptogenic zone sitting somewhere else in the frontal lobe, and you are having symptoms, or the semiology looks at as if they are originating from another part of the brain. So for the focal clonic motor seizure, the symptomatic zone is a primary motor cortex. Now, the seizures can be originating from anterior or the posterior of the primary motor cortex. So this area may not be solely responsible, is not an epileptic area. The area could be in the front, area could be a little bit posterior to that. The patients are aware. The biggest thing of these seizures are their unilateral clonic movements of the extremities, torso, and face. Patients report cramping of hand or foot. How many times just this kind of a symptom goes unnoticed and undiagnosed? Jacksonian march. They are not day or night specific. These seizures, they can evolve into epilepsia partialis continuum. So here is an example. I'm going to go to the video for this one. These videos are taken from the International League Against Epilepsy, Epilepsy Diagnostic Manual. So let's play this video of this young kid here. So you have very asymmetric movements of the limbs. If you look at the face, the tongue, those muscles are involved too. These are focal seizures, and almost 100 or more can happen during the day. Right, gonna go back to the slides. The second category of seizures from frontal lobe is asymmetric tonic seizures. These seizures, they were once misdiagnosed as parasomnia. The reason being, there are some of the symptoms which kind of look like patient has some sort of sleep disorder. Symptomatic and epileptic zone is a supplementary motor area. So we are out of the primary motor cortex. We are anterior to the primary motor cortex. So that's where the symptoms are. That's where the epileptic zone is. Along with the supplementary motor area, anterior neocortex can also generate these seizures. Patient's consciousness is preserved. There is absolutely no postictal confusion. But it does happen. That's what makes them confusing. If the seizures do not generalize, if they remain focal, there will be preserved consciousness and no postictal confusion. Patient will be doing cycling or stepping movements. There is tonic posturing of the extremities, which is maximal at the upper extremities. Sign of 4. That is the famous semiology of the frontal lobe asymmetric tonic seizures, where both the upper extremities do two different things. The EEG findings can be non-specific. So now this paroxysmal nocturnal dystonia, that is the epilepsy. That's where these seizures are being seen at this epilepsy. Okay, so this is a video of a pediatric patient having focal tonic motor seizure. The seizure is brief, but the EEG changes are pretty significant in this. So when I go to the video, I am going to the video. Here we are. All right. So the EEG changes are happening halfway through this page. High amplitude delta. There it is. That's it. So there is abduction, extension of the upper extremities. So the clinical feature is over. The electrographic features are still present. Did not appear much clinically, but if you see the EEG changes are still going on. All right, let's go back to our slides. So focal tonic motor seizures, they were present in the upper extremity. This is another example. It's just an EEG. There is no video or a picture attached to this EEG. This is taken from an article written in 2000. So this is an EEG of a typical motor seizure, left arm and leg extension. If you look at that, there are no changes in the EEG. It looks like as if the EEG is going the way it is going. There is increase in muscle activity. If you look at the EEG underneath the montage labels, that EEG is completely 1.5 seconds is sort of muscle free. And then there is increase in muscle activity. The frontal lobe seizure EEG it can be high voltage rhythmic delta theta activity or low voltage faster rhythms. So if you look clearly, some of the channels are showing proximal fast activity. So if you look here, F8T4 channel, there is a fast activity in this channel. It's very hard to diagnose this patient based on EEG. So the motor sign is the one that is a giveaway. It's an asymmetric left arm, left leg extension. So there is nothing much going on with the EEG for us to say, okay, the patient just had an event. Fencer's position, a hallmark of frontal lobe seizure. It's a supplementary motor area. And here there is an asymmetric posturing of the upper extremity. There is a tonicity here. So what is happening here? So it is described by Penfield and Jesper, the arm being raised, head and the eyes turned as though they are looking at the hand, at the raised hand. More and more patients were showing up these signs over a period of time. So they came to a conclusion, the head may turn to look either at the flexed hand or the extended hand. The ictal onset is always contralateral to the extended arm. So it means the arm that is flexed, that side is the one the seizure is happening. Rigid extension of one arm at the elbow. Fingers are either completely extended or they are in a fist, and the hand is flexed at the wrist. And the opposite arm is flexed at the elbow. This is sign of 4, M2E. I seriously could not find why M2E. How did they get to name? Sign of 4, it does make sense, sign of 4. If you look at this picture here, so it's Fencer's position or sign of 4. Look at the EEG behind. There is so much of tonic activity that the entire EEG is kind of covered with the muscle activity. And after that, there is some clonic activity where you will see these continuous sharps happening. EEG changes are subtle again here. Now, this seizure can evolve into generalized or can remain just focal and patient come out of it in less than 10 seconds. So here is an example of a focal tonic motor seizure. Note the asymmetry, the left upper limb and the right upper limb. So look at the difference between those. I'm going to go to my video here. As soon as I find one. Yes, okay. Playing video for focal tonic motor seizure. So left arm is tonic, right arm is still moving around, continuous discharges, spike and wave discharges. and the patient is looking towards the seizure. Okay, going back to the slides. Right. Hyperkinetic seizures. You do not see hyperkinetic seizures in temporal lobe. They are the frontal lobe seizures. The movements are large. It is sudden onset. Patient is aware. These seizures are easily misdiagnosed as tics. Epileptogenic zone is anterior neocortex. So anterior neocortex, this area, we have orbitofrontal, mesial, and dorsal frontal. So basically underneath the frontal lobe, that's where these seizures are originating. The seizure have complex behavior and hypermotor automatism, compared to temporal lobe seizure, where the automatism is not of very high amplitude movements. Complex behavior, hypermotor automatism is a hallmark of frontal lobe seizures. The patient is rocking back and forth, to and fro, thrashing, jumping, cycling. And these motor manifestations, they come with vocalization. Patient is screaming, swearing, yelling, shouting, grunting, making barking sounds, laughing, and whatnot. So automatism with sexual content is also reported, genital manipulation and pelvic thrusting. And these seizures are misdiagnosed as psychogenic attacks, and in some cases even tics, because of the vocalization, cussing and swearing and rocking. Here is an EEG example for hyperkinetic seizures. There are no localizing signs. You cannot say that, okay, the seizure is originating from the frontal lobe. It looks like it's everywhere. It's all over the place. The patient was awake, rocking back and forth, having fidgeting movements during this. The bottom one here is after kind of the muscle activity settles down, you see sharp spikes and wave discharges and rhythmic activity. Here is an example of hyperkinetic seizure. And look at the patient's lower extremities in this video. And extension of the arms. The patient was very much aware, and it was a brief seizure. All right, going back to slides. Another example of hyperkinetic seizure, here there is lower limbs tonic features in the upper limbs. It's more or less similar to what we just saw. So I'm going to skip this particular video here. This one here, this seizure is happening during sleep, hyperkinetic movement. The patient has pelvic thrusting, bipedal automatism, and there is an arousal after that. Let's look at this video. All right, here we are. And if you see in the back, low voltage rhythmic fast activity and T3, T6 area. Frontal absence seizures. Now these seizures, actually there is no difference between the frontal absence seizures versus generalized absence seizures. Consciousness is altered. This is the category of seizure where there is minimal motor involvement. These seizures are brief, distinct, and they can even last for hours and days, so can lead to non-convulsive status epilepticus. Patient appears normal, like as if nothing is going on, but they are confused. However, they are unaware of the events during frontal absence seizures. And the EEG looks just like generalized absence seizure, 3 Hz spike and wave activity. Masticatory or opercular seizures, these are originating from the opercular region, the frontal operculum. Epileptogenic zone, that's where it is, right above insula. The features are chewing, swallowing, excessive salivation. Patient is aware. Now, this operculum, that's where Broca's is. So if it is happening in the dominant hemisphere, there will be expressive aphasia. I have 2 videos to show you for non-convulsive focal frontal lobe seizures in ICU. Let's look at that video here. It's, I think, over a minute long video. In this, you will see multifocal left hemispheric discharges, which evolve into left central seizure. It's a non-convulsive frontal lobe, non-convulsive focal frontal lobe seizure. Let's look at that. So if you compare the discharges between the central and the temporal on the left, they are completely different. There we are. No. So it is left central, predominantly at the left central. So this seizure it could be due to lesion in the brain or a bleed in the brain on the left central area. So almost 45 seconds to 1 minute long focal seizure. Right, a few more seconds. Let's go back to our slides here. Now this one is a little different. It's not a full-fledged event happening there. Frontal-central LPDs. We have brief intermittent rhythmic discharges and brief seizures. I mean, it's very subjective to call it seizures. Is it happening for 10 seconds, 9.5 seconds? That's what is happening, but this is a perfect example of left frontal-central LPDs. Let's look at this one. So basically frequent discharges, birds, and 9.5, 10 second of activity, which is classified as seizure here. All right, let's go back to the slides. So it's difficult. Sometimes it's difficult to distinguish between the frontal and the temporal lobe seizures. The reason being the orbitofrontal and the mesial temporal areas are so close to each other. So if the seizure originates, let's say, in the orbitofrontal area of the frontal lobe versus the mesial temporal areas, and so if they are spreading, they will spread to either direction, right? They can either go to the entire temporal lobe, or they can go to frontal lobe, or they can become generalized. Olfactory hallucinations, that is a very kind of common feature between both frontal and temporal lobe seizures. Another one is chewing, lip smacking, and the manual automatisms. They kind of get confused with temporal lobe seizures. Most of the motor movements in frontal lobe seizures that we see are of very high amplitude. But some of the movements, depending on what area of the frontal lobe is getting affected, where the seizure is coming from, the patient may have some sort of smaller motor movements, like chewing and lip smacking, which is very similar to the temporal lobe seizures. What we require is neuroimaging, intracranial EEG, to confirm if they are frontal seizures, are they originating from frontal or from elsewhere. And other thing that to remember is, like I said before, the frontal lobe seizures are of very high motor amplitude compared to the temporal lobe seizures. If the patient is having hyperactive seizures, which are coupled with loud vocalization, they can be diagnosed easily as psychogenic events. The EEG changes of many of frontal lobe seizures is very subtle. It's hard to figure out if there is any electrographic changes that are happening. So they can be easily diagnosed as psychogenic events. Again, asymmetric tonic events, along with bizarre behavior, they can also be diagnosed as psychogenic events. Patient having 0.5 to 3 hertz bicycling motion. It's a repetitive limb movement, right? Happening in sleep. So is it parasomnia, or is it frontal lobe seizure? These symptoms, they appear during sleep. Now, if the patient is waking up after this pedaling movement, it is definitely a frontal lobe seizure. If the patient remains asleep, it will be categorized as parasomnia and not a frontal lobe seizure. Any seizure that originates in frontal lobe during sleep, there is arousal, no matter how brief it is. There is an arousal of the frontal lobe seizure. So that's a differentiating sign, post-arousal after frontal lobe seizures. What's the treatment? Any epileptic med that is out there, most of them, I shouldn't say any, Keppra, lamotrigine, carbamazepine, phenytoin, valproic acid, they are all used as first line of treatment for the frontal lobe epilepsy, for the frontal lobe seizures. Now, if these AEDs fail, the resective surgery is the answer to it. It is very difficult to do resective surgery in patients with frontal lobe epilepsy or frontal lobe seizures due to eloquent cortex. So we have to map the brain. Now, what if the epileptogenic zone is sitting right in the eloquent cortex? The patient is going to have quite significant deficits after the surgery. So is the resection even possible for those patients? The next thing to go to is if they cannot go through resective surgery, if they do not qualify for resective surgery due to epileptogenic zone sitting in the Broca or in the motor cortex, they go for colostomy or they go for the vagal nerve stimulation. Now, lately, from last 10, 12 years, responsive neurostimulation is another way to go to deal with frontal lobe seizures. So this device, it detects the seizure as they arise and then stimulate the brain to slow it down or to stop them. Now, deep brain stimulation is another technique that is being used if the resective surgery is not a possibility, which provides continuous or intermittent stimulation to the area. Once the area is recognized, okay, this area is the one that is causing the seizures, the deep brain stimulation device can be pre-programmed. It is continuously stimulating that area so that the patient does not get into a seizure. So those who are taking your CLTM boards, this is one of the things that is very useful. These are some of the resources I used, some articles and lots of free information on the web here from International League Against Epilepsy, neuromodulation, some research articles and review articles I used. So the takeaway point is how to differentiate between frontal and temporal lobe seizures and from psychogenic seizures. Frontal lobe seizures happen during sleep. Patient has arousal. Patient has large motor movements during the seizure. Even if the EEG changes are subtle, the movements, the semiology of the seizure is kind of asymmetric. Either both upper extremities are involved and they're doing two different things, or one arm and one leg is involved and they are also doing different things. So those are some of the takeaway points to distinguish frontal lobe seizures from the other categories.
So if you have questions, I'm going to ask you to enter them into the chat area, and then I can pose those questions to Dr. Kaushal. So we do have a question in regards to sleep stage and whether or not any particular sleep stage affects seizure activity, frontal lobe seizure activity.
It's usually stage 2 sleep. Stage 2 sleep is the state. Transition state is 1, but the frontal lobe seizures usually happen during stage 2.
All right. Well, there aren't any additional questions at this point, so I think we will end the session here. Thank you again. Appreciate all the information that you've provided. It was great. And we look forward to having you again at a later date. And hopefully the attendees here will be back for another session. Thank you and good day.
Thank you, everyone.